The second person I'm pleased to introduce is Dr. Paul Kurdyak, who, as I mentioned before, is the lead of the Institute for Clinical Evaluative Sciences Mental Health and Addictions Research Program. And he's also the medical director of performance improvement at CAMH and associate professor in the Department of Psychiatry at U of T. He is well known, I think, probably to everybody in the room because he advises just about every organization, ministry, and service provider that has anything to do with mental health in Ontario. So I was really looking forward to coming up to this microphone because earlier on I saw a bird flying around, which I normally only see in churches, and the sound from this microphone is kind of like those Sunday morning televangelists. So while I have a near religious devotion to work, if I lapse into fervor that's unbecoming, I'm hoping Mike Schull will let me know. I do want to take a little bit of a break. We've talked about the need for integration amongst ourselves, but I wanted to take a little bit of a break and remind us why we are all here, why we're doing this. And I was driving with my wife on the weekend, and we were listening to a CBC documentary, and the documentary maker was an individual who had struggled with OCD. One of the segments was an interview with a mother with 2 daughters, and for this family, lightning really struck twice. One daughter had come down with cancer, and the other was struggling with OCD. And one quote really struck me, and that was the mother said, if I had to choose between OCD and cancer, I'd choose cancer hands down. That's not because cancer is such a great situation to be dealing with, but when you listen to the relative experiences of struggling with cancer versus OCD, in cancer, they were given great information about what they were dealing with. The treatment occurred right when it needed to occur, and they got exactly what they needed. And even after the treatment, the daughter with cancer, through Make-A-Wish Foundation and all these other agencies, was going to, part of her recovery was being with other kids to have these amazing experiences. By contrast, the mother described how she had to fight and fight and fight and fight for people to understand what her daughter's OCD was, to get services, to get treatment, and that's why she would choose cancer hands down, which is a remarkable phenomenon. I think some of what you saw in Astrid's presentation and our work kind of reflects that, and to me, that's what gives meaning to the work, in addition to all the importance to policymakers, is that we use we have the privilege of using large data to validate at a population level these individuals' experiences. In the spirit of integration, this work is embedded in sorry, this does float in and out. This work is embedded in a larger bit of work. So we've heard about the Leadership Advisory Council, and Upala Chandrasekhara and I co-chaired a task force for data performance and measurement. And the goal of that task force was to develop a scorecard and then subsequently to work on a data strategy to move things forward. This was no small achievement. For the first time, and believe me, I don't expect you to read that, for the first time we have a sector-wide scorecard, performance measurement scorecard. Whereas previously there would be little pockets of measurement in the addiction sector, little pockets of measurement in the community mental health sector, little pockets of measurement in the acute care sector, we all got together with representation from all those sectors and said, enough. We need commonality, we need standardization, and we all need to be measuring the same things. So with that, there isn't it's not an apology, it's just a fact that what I'm going to be presenting to you is largely representative of the acute care sector, and that fact is based on the notion that that's really the data that we currently have access to, but I'm also going to be talking to you about efforts to rectify that. The top part of the scorecard are indicators that we can currently measure the bottom part are indicators for which we believed were of tremendous strategic importance, things like wait times. You can't have system accountability without wait times. We can't do that currently, so that's an example of something we need to keep as a high priority as we move forward with the data strategy. First, so what I'm going to be showing you now is a combination of work that we're developing for the adult scorecard, which will be released later this year. In addition to that, I'm going to be showing you a little bit of the highlights of the sort of the deeper dive work that Astrid referred to that gives context to the indicators we do. So the first is a map that shows the patient visits per population by region, where dark refers to higher rates and light refers to fewer rates. And the range, you can't see it, is in the light rates is about as low as 40 visits per 100 individuals, and in the dark, which would be sort of the Toronto Central Limb there, up to 95 visits per 100. So there's a twofold difference, and this refers to primary care, mental health related visits, and psychiatrists. And this is the same kind of regional disparity that Astrid showed. The next drills down onto psychiatrists, and here we see the same spread, but here the range is 6 visits per 100,000 in the lightly shaded areas, all the way up to 47. So we're getting into an 8-fold difference in the number of visits to psychiatrists by region. Why would that be? This is part of the deeper dive. There are 2 things on this map, a similar shading. The black refers to areas with very high numbers of psychiatrists per capita. The lightly shaded areas are areas with very low psychiatrists per capita. I'm going to only focus on the red crosses that you can see. And the red crosses refer to areas where more than half the psychiatrists in the area are more than 30 years from med school graduation. Another way of saying it is more than half the psychiatrists are near retirement. So when you have a white or a gray area paired with a red cross, you are in trouble. And those same areas are the areas where there's very little psychiatrist access to begin with. So when you put this all together, we have a real crisis because we have areas that are already struggling with access to psychiatrists, whereas psychiatrists are about to leave the system and there's no clear plan for replacement. Next, I'm going to be talking about the acute care access issue and the transitions piece. We are seeing, as we saw, although less dramatically in the child and youth scorecard, increases in emergency department use for mental health and addiction reasons, and small increases in hospitalizations. This is age-stratified 30-day readmission. So the first point is that even though we're seeing increases in the number of hospitalizations, it doesn't seem to be, if readmissions is kind of the canary in the coal mine of the hospitalization system, if you start to stress the hospitalization system, you might assume that you start to see higher readmission rates. That's not occurring yet. But what's more troubling is what we see in terms of the age issue. That is that younger patients who've been discharged are much more likely to bounce back than older patients. And we have seen, we're starting to see an actual reduction in our already low rate of post-discharge follow-up. So it goes from 2006, overall 37% down to 35, a small reduction. The yellow line refers to primary care follow-up, and primary care physicians are doing the lion's share, and that's where we're observing the reduction in follow-up. And as we've seen before, there is tremendous regional variability, and we've already seen where there are providers, there's better follow-up. Where you live really determines the success of your transition leaving the hospital. Astrid talked about this access indicator, and I want to talk a little bit more about it because I think it's so important. Every story we hear when we work clinically, what was talked about by the mother on CBC is access, and we have virtually no, until the development of this indicator, virtually no indication of access. And the way this indicator works is we take somebody who's shown up to the emergency department for a mental health and addiction reason, use the fact that we can stitch together the physician information to the emergency department information, look back 2 years, and if they've had no contact with a physician for a mental health and addictions issue, which is primary care or a psychiatrist, that means that that individual showed up to the emergency department virtually unknown to the system prior to that contact. And again, this doesn't involve the community mental health and addictions systems, but it's the best we can do. We have no benchmark for what this should be, but 1 in 3 individuals are showing up to the emergency department invisible to the system prior to presentation. And in the absence of a benchmark, I would hazard to guess that that's actually quite high, that we would like to see that. I don't think we'd ever get that to 0, but we would like for fewer than 1 in 3 individuals to have access to care prior to their visit. Good thing is that there is a severity gradient. Individuals with a diagnosis of schizophrenia are much less likely to be invisible to the system, whereas individuals with anxiety disorders and substance use are much more likely to have been invisible to the system. A bit of a deeper dive. Over the last 15 years, there's been a widespread implementation of early psychosis intervention programs. Dr. Kelly Anderson, an affiliate scientist with our research program, took a look at individuals at their first time of diagnosis for a psychotic illness. And again, we have regional programs to increase access. What she found was that within a month of your first diagnosis, guidelines are you should be seen within a week, unless there's an acute issue, that you should be seen within 48 hours. 40% of individuals saw no physician after their date of their first diagnosis. 60% did not see a psychiatrist. This is so critical for this population to get the services they need exactly when they need it. They can't wait. And there's a clear relationship between timeliness of care and outcomes. So this is an extremely important study, and this is a little old, so we're going to replicate it, and we may find that the systematic rollout of the early psychosis intervention programs have rectified this to some degree. This reflects the indicator we have. Which was what is the mortality? This is what we call a big dot. What's the mortality story for people with mental illnesses in Ontario? And this is the work of one of our epidemiologists, Jenny Gatov, and the rest of the team. What I'm showing here is a story of early death. The indicator is years of potential life lost. It's a way of measuring likelihood to die early, weighted for people who die when they're young. And if you have a diagnosis of schizophrenia, you're 5 times more likely to die early. And we actually did a larger study that's coming out in CMAJ, and the bigger story is actually fascinating, because over the past 20 years, and this is Laura Rosella's work, we've seen a remarkable reduction in mortality in the general population. And that reduction in mortality is due to people surviving or being less likely to die from cardiovascular illnesses. And what we were able to show is that if you have schizophrenia, you have completely missed out on that public health phenomenon of reduced mortality. Your likelihood to die from cardiovascular illnesses has been flat if you have schizophrenia in the same time period. And in addition to that, you're likely to die you're much higher likelihood to die for all reasons. So this is a really important area where it's not just about providing mental health care to vulnerable individuals, but to figure out ways to integrate care. And I don't think, it's not just our jurisdiction, nobody in the world has figured this out. There is a real cost to the mortality and the medical care issue, and this is work by Claire de Oliveira, a health economist at CAMH and an affiliate scientist. And again, I realize the lighting's bad. What Claire did was she took everybody with a diagnosis of schizophrenia in, I think it was 2013, let's say it's in 1 year, and calculated costs. So what we had was an entire population in Ontario with schizophrenia, and you could see healthcare costs over the lifespan, essentially. And overall, over $2 billion spent to treat Ontarians with psychotic disorders, but the really interesting piece of it was where the healthcare dollars were going. Not surprisingly, at the age of first diagnosis, you see a very large spike in psychiatric hospitalizations. What really struck me in this study was starting at the age of 45, you started seeing nursing home costs and medical costs. And this is one of those things where the data actually tells you something that's kind of obvious. What happens at the age of 45 and over for people with schizophrenia is if they've had family who've provided support and those family get elderly, the parents get elderly or pass away, our system has no response other than to place these individuals with nursing homes at the age of 50 to live the rest of their lives amidst people with 80 years old with dementia. This is and what Claire's work shows is not only is this a terrible outcome for that individual, it's also costing us an enormous amount of money because the cost of a nursing home care is far greater than supportive housing, which is what these individuals really would benefit from. I really do feel like this is very church-like, so I'll move on to future directions and try and lighten up the mood. So in moving on, this was just sort of a taste of what we're doing. We are developing contextual indicators and performance indicators in the scorecard. We are busy pulling it together. It will come out later this year. We are working in close collaboration with the data task force that I described to you before, and the Ministry of Health and Long-Term Care to help shape a data strategy that moves forward the preliminary work that we've been able to do. And I mentioned the huge gap in our ability to map the trajectory of the entire system, and specifically, we don't know what the intersectionality is between individuals who end up in hospitals and emergency departments versus over the 180 community-based addiction services and all the community mental health services. And we are currently in the Toronto Central LHIN, we have community-based mental health and addictions data linked to ICES, and we have a working group busy doing really innovative, actually I think it's unique to the world probably, the ability to map what's happening across the entire sector. We have linked the Ontario Community Assessment of Need data, which is provincial data collected in community mental health agencies, and we are very, very, very close with colleagues at DATIS, the Drug and Alcohol Treatment Information System, to bring in addictions services data to really understand in much greater detail what is happening across the entire sector, which is so critical to really understanding the true performance. I just wanted to take a bit of time acknowledging the team we have working for us. It's just an amazing team, and we work very hard. We have a lot of fun. We have three epidemiologists, Abby Amarty, Jenny Gatoff, and Michael Liebenbaum. We have our scientists, Maria Chu, Simone Vigod, and Natasha Saunders. and we have Julie Yang, and I want to especially acknowledge Julie Yang. She's our project manager, and for today, she's been our wedding planner. I mean, she's just pulled this together. So a special shout out to Julie for all the work she's done. Thank you very much, Julie. We also have had a lot of input we get a lot of input into these reports. An army of analysts at ICES does the analytic work for us. We even had a geographer help us with our maps. We've had analytic input from an MCYS, and we've had real experts provide external review to make sure that the message is on point. Finally, we've received data from other sources outside of ICES and acknowledgement that ICES receives funding from the Ministry of Health and Long-Term Care. With that, I'll end. Thank you very much.